All right, welcome back, everyone. We're now going to head into our panel session focusing on GU cancer.
Good morning, everyone. I'm Dr. Jingsong Zhang, medical oncologist at the Moffitt Cancer Center, primarily treating prostate bladder cancer. I have here with my colleague, Dr. Chadha, who is a medical oncologist, worked with us with a focus in GU oncology. He also worked at the Wesley Chapel location as well. Sarah is our wonderful physician assistant, has been with us for more than 2 years, right? So help us a lot on seeing those prostate cancer cases. So I was told to do a more like a case-based interactive discussion. It's a very broad audience, so we focus on the 4 notable advancements in the past 2 years, and then it's more like a case-based discussion. We won't go into details about the phase 3 trials, but just start with the indication and then talk about how we utilize this indication in the clinical setting. So I'll get started. So prostate cancer, when you see a patient in prostate cancer, the first question is staging. So most patients these days diagnosed with localized prostate cancer, either they select surgery or radiation. Regardless of the initial Gleason score risk factors, all comers, about 1/3, they will recur. So unlike all the other cancers, the prostate cancer, you have a very specific tumor marker. PSA after surgery is supposed to be 0. When it's become detectable going up, the cancer is back. Radiation, they have the old Phoenix criteria. If it's going up, reach 2+, the nadir, that's recurrence. Some patient has late recurrence, you do a PET scan, it's negative. You could treat it with salvage radiation if the previous treatment is, surgery. For people had a surgery, had a radiation before, salvage prostatectomy is rarely done because the comorbidity, the urinary incontinence rate is up to 50%. For selected patients, it could be a salvage cryoablation. Those are more like a urology scenario. We got a referral for patients with PSA recurrence or biochemical recurrence, essentially a group of people with rising PSA. We know the cancer is coming back, but clean scans. So those kind of the gray zone, we don't really have a clear guideline. Most of the patients, they do intermittent therapy. There are some trials, being done and their data coming out in this stage of prostate cancer, but there's really no clear guideline how to manage. But some of those, they do get androgen deprivation therapy. Eventually they become resistant. A small subset is M0 castration resistant. Essentially, the PSA rising while on the leuprolide or Eligard injection, but still, has clean negative scans. And then we have indication for 3 AR inhibitors in this setting. And then there's a subset of patient was diagnosed with prostate cancer metastatic diagnosis, also called de novo metastatic prostate cancer. This is actually the more aggressive subset. Typically, after about 2 years androgen deprivation, they will become castration resistance. And then after the diagnosis of castration resistance, the average life expectancy is about 3 to 5 years, even with the modern therapy. So nowadays, we have lots of treatment approved for treating prostate cancer, but for stage 4 disease, we don't have a cure. The most effective treatment is still the androgen deprivation therapy. It's just a medical terminology for chemical castration. If the patient elect to surgical castration, you can achieve the same goal of reducing the testosterone. So the commonly used LH-RH analog, including the agonist, that's the old ones, leuprolide, goserelin, triptorelin. And then more recently, we have the antagonist, dagorelis, and then the only oral agent is rilugolide. So the advantage of antagonists, they drop the testosterone faster. You don't have this theoretical initial flare of testosterone in the first 2 weeks. When we do the androgen deprivation therapy with this LH-RH analog, essentially the cancer cells start to make their own testosterone, and the adrenal gland can also make a little bit testosterone. So the recent advances mainly look at blockers to block the androgen action. Those are called AR antagonists. So the old school drug is bacalutamide, the second generation enzalutamide, apalutamide, darolutamide. We also have a drug not listed on the slide, abiraterone acetate. It actually blocks the production of testosterone by the adrenal gland and the cancer cells. So that's the background slide. So the first advancement we like to talk about is the approval and the introduction of PSMA PET scan for prostate cancer managing. So there are 3 PET tracers approved, they all, works about the same. Gallium-68, PET-Arify, and then the most recent Posluma. Essentially, they are approved to stage intermediate high-risk prostate cancer before they go to surgery or radiation therapy. And then they can also look for early metastasis for patients with biochemical recurrence. Sometimes you can upstage to M1 disease. Some patients are motivated to do more ablative local therapy like a radiation. And then the third utility is mainly to select patients with metastatic castration-resistant prostate cancer for treatment like radioligand therapy. We'll talk about things like lutetium-177. One thing has been noted in the community, there's a bit misuse of this PET scan. We don't know how to use the PET scan to follow up the response. So patient with metastatic disease detected by the PET scan, you start on ADT, the PSA go up, you need to do another PET scan. We don't really know how to use it to interpret the response. Sometimes you may still see some uptake, even the PSA had a nice response. So we'll start with case number 1, and Sarah will present the case.
All right, so this is a 63-year-old male who was found to have a PSA of 33 and a positive DRE during routine screening. Prostate MRI revealed bilateral prostate cancer with left seminal vesicle invasion. This was Gleason 9, 4+5 on biopsy. So he underwent a PSMA PET scan, which reported increased uptake in the prostate gland, along with a 12-millimeter left pelvic lymph node with SUV max of 36. So I'll ask Dr. Zhang and Dr. Chadha, what is your treatment recommendation for this patient? Would you start combined ADT with leuprolide and apalutamide for his stage 4 T3B-N1 M0 prostate cancer? Would you recommend a radical prostatectomy with lymph node dissection? Or start combined ADT with leuprolide plus abiraterone and prednisone, followed by definitive radiation to the prostate gland?
So looking at this clinical scenario, my thoughts, I think that the option C, so starting with ADT, leuprolide plus abiraterone plus prednisone along with radiation would likely be my preferred choice, and this is based on data from the updated STAMPEDE trial for patients with either local non-metastatic high-risk prostate cancer or patients with N1 disease. This has been, I think, personally practice-changing, and this has shown actually in 6-year data metastatic free survival benefit for patients with the addition of abiraterone to ADT and radiation. I still think it's reasonable to go with A. There is data per the TITAN trial to add a novel hormone agent like APA. In the trial itself, there were about 10 to 20% of patients who were N1 disease, not necessarily M1 disease. So we do have 4-year updated survival data from this trial, so I think that's also reasonable as well. I would probably hold from doing a radical prostatectomy. We just don't have level 1 evidence in the setting of stage 4 or 4A disease like this gentleman has. Most is retrospective or single center. The other thought is once you get a surgery, your node is going to be positive, so you're going to deal with toxicities of a surgery and likely require adjuvant hormones and radiation. So it's just kind of adding to the toxicities combined.
Yeah, so very good discussion. So essentially I highlight here in orange the risk factors, the PSA value, the seminal vesicle invasion, the Gleason score. So any one of them would qualify him as a high-risk disease. So he's metastatic on the PET, the lymph node is only 12 millimeter. If you use a conventional CT scan, he probably consider, N0, M0 disease. So one caveat about, combined androgen deprivation therapy. So unlike TITAN trial, all the other phase 3 studies, they tend to exclude people with N1 disease only. So the interesting part about prostate cancer staging, N1 is considered stage 4. You can have 1 lymph node qualify N1, you can have 10 lymph node light up, still N1, but it's all stage 4. Stage 4 means it's not a curable disease. At least with the treatment we have right now, it's more like prognostic value. So unlike other cancer, N1 is more group at stage 3. People try to treat it with curative intent, chemo followed by surgery. So the data, the radical prostatectomy lymph node dissection is being evaluated ongoing SWOG study. We occasionally offer it to young motivated patient. The idea is if you caught it early, the lymph node may already have not spread outside the pelvic area. If you do a full dissection, you may have a more complete staging, at least debug the tumor. But things like urinary incontinence, erectile dysfunction will certainly go up when you go do an extensive lymph node dissection. So C is most commonly used approach. That's also the approach with the level 1 evidence. So this paper was published, I think, in Lancet 2 years ago. Essentially look at the two arms of the STAMPEDE study. The idea is try to intensify androgen deprivation when patient goes through external beam radiation as initial definitive treatment for high risk of M1 prostate cancer. So one arm of the study combined with abiraterone, the other arm is combined IB plus enzalutamide. The take-home message, adding combined androgen deprivation therapy does improve survival. You can see the top line on the curve there. But just adding additional AR pathway inhibitor when you add enza to IB does not seem to make much difference. Obviously, that will add some toxicity. So essentially, nowadays for M1 disease, high-risk M1 disease, doing 2 years abiraterone combined with LHRH analog along with, definitive radiation treatment is considered standard of care. In terms of low-volume M1 disease, for example, if this patient has a solitary bone mass in the rib or spine, or there's another lymph node in the abdominal area, so that's making M1. The data is less clear. So the STAMPEDE data, there was analysis indicating it could improve survival, but recently in this year's ASCO, there's an update from the phase 3 Peace 1 study. There was not much survival difference. I think part of the reason is, STAMPEDE is more like early on study. So both studies are European studies. So later on, people in Europe, they have more access to more active drugs like abiraterone, enzalutamide, apalutamide, or chemotherapy, radioligand therapy when the cancer progresses. That's probably the reason we don't see a survival difference if you have more effective systemic therapy. So the second advancement we would like to highlight is really in the past few years, there are a couple of phase 3 studies to document the early utilization of androgen pathway inhibitors. So those are the AR antagonist as well as the abiraterone, the CYP17 inhibitor. So on the left-hand panel, you see the two trials, the Latitude STAMPEDE show the survival benefit of adding abiraterone early on. Middle panel is enzalutamide, and then the top right is apalutamide. If you look at the hazard ratio in overall survival, it's about 0.66, around that. So about 1/3 reduction in the risk of death. That's a significant improvement. But there's one trial which was a negative study. This trial is different than the other 5. This is a US-only study. It's a SWOG study, 1216, comparing a CYP17 inhibitor like abiraterone-like drug called TAC700 or Tylenol versus LHRH analog plus bicalutamide. So actually the SWOG study has a more active control. So LHRH analog plus bicalutamide, in the old days, there's a phase 3 data showing it's actually improved survival compared to LHRH analog by itself. The design of the SWOG study is also open label. They allow patients to early switch treatment just based on PSA progression, which is also different than the design of most other trials. So that could be the reason, why the SWOG study didn't show an overall survival difference. And then that kind of brings up the question when we're facing the patient with newly diagnosed metastatic prostate cancer, particularly de novo metastatic disease, how we re-stratify them, and then does everybody need combined ADT, particularly guys, who really hesitant about the toxicity, including the side effects from chemical castration as well as financial toxicity. And then for patients who start on combined ADT, when they achieve undetectable PSA, do you still need to continue the abiraterone or enzalutamide? Is there value to stop the treatment, kind of save it for a later day? We didn't talk about the data on the triple therapy, but there's Peace 1 as well, Arison's trial, to show the survival benefit of adding chemo to combined androgen deprivation. The caveat of those two studies, the control arm is chemotherapy. So we still don't know whether triple therapy is better than combined androgen deprivation with either abiraterone, apalutamide, or enzalutamide. So this is about the data we have on risk stratification. So in the clinical trial, we use this terminology called high volume disease. Essentially, that was in the CHARTED study and was also in the subgroup analysis of subsequent phase 3 trials. So for patients with visceral, liver or lung mets, for sure they are the most aggressive type of prostate cancer, particularly liver metastasis. Or if they have formal bone metastasis, at least one of them has to be out of the pelvic and spinal region. And then the high risk is in the Latitude trial. It's not as commonly used as a high volume disease. The definition of high risk is basically 2 of the 3 risk factors: Gleason score 8 or above, at least 3 bone metastases, presence of measurable visceral metastasis. If you look at the Latitude definition, some of the oligometastatic prostate cancer could be considered high risk. There's always debate how to manage oligometastatic disease. In my practice, if they have more than 3 bone mets, high Gleason score, I'm probably not enthusiastic about offering radiation to go after those metastatic lesions because they are high risk. The best data on risk stratification is the PSA response. That has been repeatedly shown by a couple of phase 3 trials. So the old study started with a SWOG 9346. So this is comparing non-inferiority of continuous intermittent versus continuous androgen deprivation for M1 prostate cancer. It starts with 7 months of induction phase. If the PSA drops to less than 4, then they will be randomized. This is the data from this trial. For patients 7 months into combined androgen deprivation with LHRH analog with the old school bicalutamide, if the PSA dropped to less than 0.2, the median overall survival is 6 years. So that's pretty impressive, just with the old drug, 6 years median overall survival. If the PSA stay above 4, again, those are the old data started in 1993, median OS only 21.6 months. So CHARTED used the same criteria. This is one of their secondary endpoint. Show the same thing. If the PSA 7 months with adding docetaxel chemotherapy, if dropped to less than 0.2, people tend to do much better. So CHARTED, 2/3 of people has high volume disease. So the median OS is actually lower than the SWOG study, 60.4 months. But if PSA stay above 4 even after chemo, the median OS only about 2 years. So this is for sure the group you probably want to introduce drugs like apalutamide and enzalutamide. So I'll start with the first, actually this should be the second case, sorry.
All right, so this is a 77-year-old practicing physician admitted for 10 out of 10 low back pain. His spine MRI showed a T12 pathological fracture due to lytic and blastic bone mets. His PSA was greater than 5,000. On staging CT and bone scan, he had diffuse bone mets and bulky lymphadenopathy. He underwent a T12 corpectomy, T11 to L1 internal fixation, and pathology was consistent with metastatic prostate adenocarcinoma. On next-generation sequencing, he was microsatellite stable, homologous recombination repair wild type, tumor mutational burden was low, TP53 wild type, and no loss of PTEN or loss of RB1. He was started on daguerreolex and bicalutamide while inpatient, and then seen in clinic a couple of days later with radiation planned to T10 through L1. So is this patient high risk or high volume? And then what is your recommendation? Would you add docetaxel at 75 milligrams per meter squared, add abiraterone plus prednisone and stop the bicalutamide? Would you add both docetaxel and abiraterone plus prednisone? Or would you start with abiraterone plus prednisone and add the docetaxel a couple of weeks after completing radiation?
Yeah, so this is a great question. It factors in a lot of clinical points that are important. So definitely, as far as volume is concerned, the patient has diffuse bone mets. So you would say per charted, probably more than 4 bone mets. So this would factor in. The patient's also de novo metastatic. So you would factor that in as far as some of the risk features as well. So looking at your answer choices, I think per charted, given the volume, we have data for docetaxel, so that is a consideration. In looking at abiraterone, we have data from, particularly from Latitude trial, where patients were high risk, all of them greater than 3 bone mets, either Gleason greater than 8 or visceral metastasis. This patient, we don't have his Gleason, but at least has definitely more than 3 bone mets. And the data from Latitude is impressive in that in their final analysis, there was about a 16-month difference in OS at over 53 months versus 36 months. So I think if the patient wants to avoid chemotherapy toxicities, ABI monotherapy is very reasonable. As Dr. Zhang alluded to, you could likely combine both per piece one. The benefit there also was seen more towards the higher volume group, and that was both radiographic PFS and OS. And so that's also potentially an option. I will say his molecular profile doesn't really look very high risk, and he, again, doesn't have many visceral mets, so just bulky lymph nodes. So I'd probably lean towards B, but I see rationale for a few. Maybe
Thank
C.
you. Yeah, so again, this is the old case, back to 2017. We don't have the data on triple therapy, but this is someday for sure, triple therapy would be justified. Lytic bone metastases tend to be more aggressive. There's high risk for fracture. He presents with pain, which most patients with bone mass don't really present with pain, but he's just busy practicing physician, not really have time to take care of himself. Diagnosed with PSA more than 5,000. Sometimes there's also logistics issues when you see patient in the clinic. He just released from hospital. He's pretty fatigued, weak. Adding chemotherapy may not be feasible at this time, particularly there are more radiation planned that will cause more fatigue. So start on the abiraterone combined androgen deprivation therapy would be a reasonable choice. So he started that, also had underwent the radiation therapy with, more than 80% PSA reduction. That's a pretty decent response. Back to a year later, actually less than a year later, a few months later, his PSA already dropped to 0.97. The pain is improved. So with this rapid response, symptom relief, there's really no strong indication to add chemotherapy. So chemotherapy really won't help that much. He actually, on the treatment for a while, he wanted a treatment break because, again, the fatigue, the financial toxicity, the restaging scans show no new lesions, stable bone mass. The recommendation now, you can continue leuprolide monotherapy because the PSA increase is minor, does not meet the standard definition for PSA progression. The standard definition, you have to have at least a value of 2.0. Or you can restart abiraterone plus prednisone. Or this is a candidate, his cancer is becoming castration resistant. Immunotherapy with Sipuleucel-T would be an option. The most of disease in the bone, there are no lymph node disease. The bone-seeking radioligand therapy, radium-223, would be an option as well. Or you can repeat NGS test. So repeat NGS test is not a good idea with liquid biopsy because they have very low disease burden. So the yield will be very low. But all the other 4 options above are reasonable options. I personal preference, I tend to favor Sipuleucel-T because this is a life-prolonging treatment, tend to work better when you have minimum disease burden. But again, he just elect to continue monotherapy, just concerns for financial toxicity as well as the potential side effects. So the PSA, remains less than 1, 5.4 years into androgen deprivation therapy. So his poor prognostic factor, de novo high volume disease, symptomatic at presentation. The favorable factor, excellent PSA response. Again, that's the part we have most of the data to show, the value of PSA response as a prognostic factor. He has no visceral mass, and then there are lack of aggressive features on the genetics, no loss of PTEN, RBO, T53. Cancer was wild type on the TP53. So this is kind of just quickly go over those trials. You can look at those people with overall survival 24 months, 36 months. The left upper panel is the SWOG 9346. If you look at that and then use the control arm of Titan study, Arison study, because SWOG is a US-only study, allow early switch of therapy, people actually tend to do better even with old school drug if they have a good PSA response. So I don't have time to go into the details of this discussion, but essentially the summary of the managing newly diagnosed de novo M1 castration-sensitive prostate cancer, is when we do the risk stratification, the site of metastasis, symptom of presentation are important factors, but more important factor is their PSA response, 6 to 7 months into combined androgen deprivation therapy. If you're interested, there is actually a poster this year's ASCO from the SWOG 1216. They look at PSA response at the 3 months, if less than 0.2, actually people do very well. So we could have marker early on, 3 months instead of 6 to 7 months. So this manuscript is being submitted, so you can on the lookout for it. Does every MCSPC need combined ADT? It's standard of care based on improvement survival, but for some patients, for example, we have seen people in the clinic PSA 200, and then you start on bicalutamide, leuprolide, in 1 month, the PSA dropped to less than 1. With that excellent response, they probably don't really need it. You can save those pills for a later day. I think there's no rush to make this decision, at the first visit. You can start with the traditional treatment, just get a sense how they tolerate, what kind of PSA response. If you look at those trials, people actually allowed to enroll in the study 3 months into androgen deprivation therapy. So there's no rush to make a decision. You can watch the PSA response and then make a decision later on. The question about whether to continue on ADT when continue on those new hormonal agents when PSA become undetectable, we have no data on that. In my practice, I tend to do that. You kind of save those drugs for a later day and also reduce some of the toxicity from long-term androgen deprivation. The triple therapy are mainly used for patients with liver metastasis, symptomatic bone metastasis. So the third advancement is really targeted DNA damage repair in metastatic prostate cancer. So we have the PARP inhibitors, 3 of them, actually 4 of them, approved for treating metastatic castration-resistant prostate cancer with deleterious mutations in the homologous recombination pathway. So this is the most important pathway in DNA damage repair. So it has the high fidelity to repair the double-strand DNA breaks. So the unrepaired single-strand break will convert to double-strand during the DNA replication. If you have defective pathway in this double-strand repair plus adding a PARP inhibitor, that will lead to synthetic lethality. So the first drug approved is olaparib. The initial approval is actually for 14 genes involving this pathway. Then there's additional phase 3 PROPEL data to show the benefit of doing combined treatment by adding abiraterone, particularly for BRCA-mutated patients. Rucaparib was, accelerated approval for BRCA only in the post-chemo setting. The TRITON3 was reported, ASCO last year. GU ASCO this year. The more recent approval is on the combination talazoparib plus enzalutamide for, again, the HR mutated patients. And then 8 days ago, we have the niraparib abiraterone approved for BRCA-mutated metastatic prostate cancer. So the key is really to do the testing. If you don't do the testing, if you don't know they have the mutation, then you will lose the opportunity to offer these patients these drugs. For less than 3% of M1 CRPC, they carry the mismatch repair deficiency, and anti-PD-1 therapy with pembrolizumab does have the indication for that. So I'll go to actually the third case.
All right, so in 2010, this patient underwent a prostatectomy for his stage 3 PT3A N0M0 Gleason 7 prostate cancer, and he also underwent adjuvant external beam radiation. In 2013, so 2 years later, he started on leuprolide for biochemical recurrence with a PSA of 3.6. Bicalutamide was then added when he developed M0 castration-resistant prostate cancer. We then changed the bicalutamide to enzalutamide when he progressed to M1A castration-resistant prostate cancer with mets to the lymph nodes. He then received 6 cycles of docetaxel up north with a post-chemo PSA of 2.21. He returned back down to Florida in November of 2021 with a rising PSA up to 7.6. His CT showed minor progression of a 2.28 centimeter pelvic mass at prior seminal vesicle site. So what would you recommend next here? We can add abiraterone plus prednisone to his leuprolide, sipuleucel T, a CT-guided biopsy of the pelvic mass, and send for sequencing, cabazitaxel.
Again, a great case, kind of looking through the trajectory of time here. I think at this point, also just based on what Dr. Zhang mentioned, obtaining a biopsy is very reasonable. Is the lesion accessible? Is it, above 1.5 centimeters or so? Can you get viable DNA and run appropriate testing? So, I think it's very reasonable to go with C and do a biopsy. As a FYI, I think that CYP-T, he probably fits the criteria. Just, he doesn't have visceral metastasis. He has a relatively low PSA still. We know that it's better to start that therapy with the PSA being, really as low as possible based on data from PROCEED registration study. As far as going with another a novel hormone agent, there may be some cross-resistance, so I think I would lean towards C.
Yeah, so those are reasonable options. I think A is not recommended nowadays because when you sequence those AR inhibitor treatment, we know the response rate is not that great. But if it's against chemotherapy, against all other options, it's just minor PSA progression, disease is still in the lymph node, it can be something offered to the patient. D, chemotherapy is indicated, but it's a little bit overkill. The disease burden is low. CYP-T is for sure an option. This case is a little bit unique. It's actually, the cancer is much more aggressive than we initially thought. So this is a picture of a CT-guided biopsy. He's lying on his abdomen, the needle going from the back, the bottom area, reach that pelvic mass. So this kind of molecular profiling, you probably see less than 1% of prostate cancer. He has both BRCA frame-shift mutation, basically loss of function of BRCA2, also MSH3, loss of function frame-shift mutation. And then you see the phenotype of MSI high. It's expected when you have mismatch repair gene mutation. Tampa's ERK fusion tell us, this is regular prostate adenocarcinoma started. An AR loss exon 4/8, that's probably indicating doing abiraterone would not be a good idea. Then he has additional high-risk features, loss of PTEN and TP53 mutation. Most prostate cancer, even with BRCA mutation, they don't have high mutation burden. But in his case, he has high mutation burden, 15 mutation for megabase. So now you have the option, give PARP inhibitor or pembrolizumab, chemotherapy, or sipuleucel-T. So he basically, got olaparib, has okay response. So typically for BRCA mutation, the duration response should be a year, median duration response. So his response, lasts about 7 months. The PSA start to go up, even by adding the radiation to the trouble site, pelvic mass. So now the data with abiraterone coming up, we add abiraterone. In retrospect, probably abiraterone really won't add much because he has loss of AR. So the idea behind combined treatment is mainly, targeting the AR pathway could increase the PARP inhibition, then PARP inhibitor will work better. In his case, the AR pathway is already defective due to the AR mutation. So we actually didn't see much response. He progressed with just in a month with new liver metastasis. So we have to start on chemotherapy. The cancer actually didn't respond to chemo. He wanted to take a chemo break based on the mismatch repair deficiency, high tumor mutation burden. We tried pembro, didn't see response. Add carboplatin while waiting for the lutetium, but he just passed away while waiting for the lutetium treatment. So there's subset of prostate cancer, regardless what you do, they resistant to treatment you offer. But this is again much more aggressive than we initially thought. This again highlights the importance of doing the sequencing test to learn about the cancer at the molecular level. So the last topic we are talking about is the radioligand therapy with the lutetium 177 PSMA. So this is based on the phase 3 VISION study. It's old study, published. It's a 2-to-1 randomization. Essentially, one thing to highlight is the study is looking for a population post 2 lines of chemotherapy for metastatic castration-resistant prostate cancer. If patients only have 1 line of treatment, you have to document why they cannot get carboxytazole. So it's a sick patient population. They use supportive care as a control arm. The other thing I would like to highlight, the study used a very stringent PET criteria to select patient. If the patient has any measurable lesions, has SUV uptake less than liver, they will be considered PET negative. So we actually, if you look at a good PET report, the radiologist will tell you the SUV uptake of the parotid gland as well as the liver. that's your background. Typically, the liver has a PET uptake around 7, sometimes 10. Then if you have a lymph node only 3 or 4, that's probably won't really benefit from this treatment. But nowadays, outside the trial, if it's PET active, we offer them benefit doubt with this treatment. So, the approval is based on improvement overall survival, radiographic progression-free survival. So I'll, go to our, probably the last case.
All right, so this is a 57-year-old with de novo M1 prostate cancer to the liver. He presented in 2018 with a PSA of 75. His staging workup was notable for liver and bone metastases, and his liver biopsy confirmed prostate adenocarcinoma. On NGS, he's HRR wild type, tumor mutational burden low, and MSS stable. So he was started on continuous leuprolide as well as upfront docetaxel for 6 cycles. He then progressed and was started on enzalutamide for metastatic castrate-resistant prostate cancer. Pre-enzalutamide PSA was 38. He natered down to 1.38 and then increased back up to 21.3. His scans showed overall stable liver and bone metastases. So at this point, what treatment would you recommend, and what are his high-risk features? Abiraterone plus prednisone, cabazitaxel plus carboplatin, sipuleucel T, or radium-223.
Yeah, so in this case, I would probably lean towards B, going with cabazitaxel. We do have data for patients based on the CARD trial where they have been exposed to docetaxel. They then are switched to a novel hormone agent, such as Enza or Abi. They're on it for about 12 months, but with subsequent progression. And so then that trial was looking to see, well, in that setting, do we go with cabazitaxel or do you go with the alternative novel hormone? It looks like he had a progression of about 12, or maybe a little bit more than 12 months on Enza. And that data from CARD showed an increased OS, PFS, and PSA response rate with going with Cabazi. So I definitely think this is the type of case to definitely consider that. Whether to, over A, which is Abby, whether to escalate to double it, I think that might not be the case right now given his otherwise stable visceral disease, and he doesn't have really any tumor suppressor gene mutations. He probably wouldn't fit the typical criteria of D and E just because, again, he has a history of visceral metastasis. But that might be my take.
Yeah, so this patient, although on the NGS there are no aggressive features, we know he has very aggressive prostate cancer because it's metastatic to the liver at presentation. That represents less than 10% of stage 4 prostate cancer. Liver metastases tend to be very aggressive, hard to manage. But somehow, he did have a good response. The other thing about NGS is targeted exome sequencing. So we select the target we know is linked to poor prognosis. But there are unknown targets we are not really sequencing, we are not looking. So there are some subtype prostate cancer, even without aggressive feature on the NGS test, not necessarily mean they do well if you see this aggressive feature like liver metastasis. Now he presents to enzalutamide, he still present with rising PSA with stable scans. So there's less concern for neuroendocrine transformation. So the cabazitaxel carboplatin is the regimen more commonly used for secondary neuroendocrine prostate cancer. Abiraterone prednisone is not a good idea for patients with liver metastasis. The response rate, after enzalutamide is less than 10%. That's the PSA response. Sipuleucel T, radium-223 are contraindicated. Both treatment does not work well for liver metastasis. So radium-223, again, is a bone-seeking liquid radiation therapy. So this is, what his PET scan looks like. You can see there's really a, let's see. Yeah, this is kind of the parotid gland. That's the liver. The kidney, they all have a high background uptake. So in the vision study, any measurable lesions has to be above the liver background. You can see some spot, some spot in the liver, the metastasis is a little bit above the background. You see some lymph node disease, bone lesions light up. So he was actually involved in the clinical trial combined cabazitaxel with anti-PD-L1 as well as adenosine inhibitor. The trial is an active study, but he did have a good response. But he presented with symptomatic progression with epidural metastasis, L3, L4, taken off the study, got radiation therapy, later has rising PSA. So, you can see that there's lots of disease in the bone in the pelvic area. So those locations are the risk for fracture as well. So this is basically the PET scan that we did after he progressed through the study. So he had a lutein treatment. There was some dose delay because after the first dose, he has pain in the right hip. Based on the aggressive feature on the PET, we have to give radiation therapy. But if you look at the PSA curve, after second dose, there's really no PSA. Oh, sorry. There's really no PSA response. The PSA just rapid doubling. And then symptomatic, he's also getting more bone pain with rapidly rising PSA, cord compression, soon after second dose of Pluvicto treatment. So the nice thing about lutetium-177 PSMA, unlike the radium-223, the previous radioligand therapy, the PSA is a very good indicator of response. So this data was presented at ESMO last year. You can just look at this graph here. This is the radiographic progression-free survival. This is the overall survival. Patient tend to do best is the patient with more than 90% PSA drop after 2 doses. This is at week 12. The radiographic progression-free survival is 20.3 months. OS, was not reached when the data was presented. This is the group with no PSA response. That represents about 1/3 of vision population. Probably will be higher in the general practice because we use less stringent PET criteria. So they do poorly. Essentially will have radiographic progression. 50% of them will have radiographic progression before the third dose. So in our practice, when we see no lack of PSA response after 2 doses, that's the time to change treatment. Sometimes we see that referral from communities, they go through treatment. Clearly, the cancer is not responding, then they become cytopenic from repeated radiation therapy. We will not be able to treat it anymore because of the thrombocytopenia. So this is, again, the take-home message about lutetium Pluvicto treatment, check the PSA. If it's not going down after 12 weeks, consider switching therapy. So I think we don't have time for the last case. We'll just quickly go to the summary of the 4 topic of the, we discussed essentially approval, PSMA PET scan to stage intermediate high-risk prostate cancer, early identifying metastasis for biochemical recurrence, select patient for radioligand therapy like lutetium PSMA. Then combined androgen deprivation therapy with early utilization of the normal hormone agent to treat particularly de novo M1 castration-sensitive prostate cancer, and targeting DNA damage repair with PARP inhibitor or PARP inhibitor-based combined treatment for M1 CRPC with HR mutation, and then for select group of people with MSI high, or high tumor mutation burden, anti-PD-1 can be an option. And then we discussed the radioligand therapy and then the role of PSA monitoring. So I'll stop here, have 30 seconds for question.
Alrighty. Thank you all for a great presentation. Are there any questions?
For these patients that present with an obstructive uropathy and we end up getting called in the hospital, they put the nephrostomy tubes in, I kind of feel that urgency of going to cytotoxic chemotherapy. What was your thought on that?
Yeah, so I think that's typically the T4 prostate cancer invading the UVJ. You put a PCN catheter. You might experience chemo really not adding that much because it's a local disease. They tend not to respond well to systemic therapy. Typically, I use combined ADT with abiraterone. Abiraterone is pretty safe for the kidney. And then typically you will see a good PSA response. After that, you can repeat the prostate MRI or pelvic CT, or even repeat a cysto, to see whether you can internalize the stent. If there is lack of response, adding DASI is certainly an option. The nice thing about docetaxel is metabolized to the liver, so you can get to people on, hemodialysis. The same thing for abiraterone. Both agents are very safe for the kidney. It is a challenging situation for T4 disease. It's more challenging if you see MRI, the cancer is approaching the rectum. Sometimes they cause bowel obstruction. So those are the patients I tend to repeat the imaging regardless of the PSA response. Just make sure the local response. If not, you will add radiation therapy. It's more effective than chemo.
So the question is related to the PSMA for staging. So 2 questions. How is it going to affect the AJCC staging of patients? And how is it going to affect future sort of trials? So if you have a patient, high-risk disease, high glycemic score, high PSA, and the PSMA is positive, 1 lesion, 1 centimeter in a bone, what does it mean to the patient? How do you select your treatment? What is the future for such patients?
Yeah, so HHCC current staging is still based on the conventional CT and the bone scan, but we do know, the PSMA PET is really specific. It's not 100%. Melanoma can light up, and there's published literature solitary rib lesion. It tends to be a most common, false positive. But if you see a spinal mass on the CT part, you see a sclerotic lesion, then that's real. Then we consider this is stage 4 disease. The prognosis, I think, you can certainly be aggressive, add combined ADT, radiate the prostate, radiate that single spot with metastasis if it's relatively fit patient, like less than 75 years old. But we don't have data in terms of, adding the radiation to the metastatic site will really improve the survival. We talk about the PIS1, they don't really see an OS difference. STAMPEDE do show, there could be a OS difference, adding the radiation to the primary. The idea of radiating the metastatic site is from an old Nature paper, is from rapid autopsy. When they sequenced the tumor, found out other than the prostate gland, the bone metastasis, lymph node metastasis can also give rise to metastasis as well. So that's kind of the idea, to advocate, go after solid oligometastatic site. But we don't have, solid data in terms that will really improve the survival.
So what I'm trying to get to, you have a young patient, prostate cancer, high glycemic score, PSA is elevated. Let's assume he had a bone scan, which is negative. Let's assume he had an ordinary PET scan, which is negative. Now we have this available, the PSMA. He has a small focus in the bone, which is positive, unequivocal, positive. So he's sitting in front of you. Does he have a curable disease or non-curable disease?
Not curable. This is stage 4, not curable. Even if it has 1 lymph node, that's better than the bone. It's not curable. It's called stage 4.
All right, thank you all again for an amazing discussion.